Good afternoon and good morning to everybody out there, and we appreciate you spending your lunch hour or perhaps late breakfast if you're on the West Coast with us. And I am George Huntley. I'm the Chief Executive Officer of the Diabetes Patient Advocacy Coalition. I'm a type 1 patient and have been a diabetes advocate for 30 plus years. I'm joined today by my good friend, Mr. Stuart Perry. Stuart is my partner in crime, that's Stuart, and he's the vice chair of the Diabetes Patient Advocacy Coalition, as well as the chair of the Diabetes Leadership Group. He's a type 2 patient, also an advocate for 30 years, and we're kind of joined at the hip, even though we're in different cities at the moment.
You'll notice the same shirts.
We do have the same shirts. We dressed ourselves today, and both of us have pretty extensive experience in the health insurance arena as we get into this dialogue today. So again, thank you and welcome for being, thank you for being here and welcome. Very quick on the DPAC mission. Our mission is to ensure quality of access and access to care, medications, devices for patients living with diabetes, to educate, inspire, and empower patient advocates, as well as lawmakers toward meaningful action on diabetes. And we do that through sessions like today, through educational sessions on topics of interest and importance for people with diabetes. So again, thank you for being here. Quickly, the Diabetes Leadership Council is an affiliate of the Diabetes Patient Advocacy Coalition. So we are now affiliated organizations. DLC provides policy expertise. Everybody on the DLC board is a longtime advocate and a past leader of a national level diabetes organization. The DPAC organization is the grassroots army. This is the grassroots folks that are the champions on this call, who are empowered to take action and weigh in on issues through the combination of DLC and DPAC. It's a powerful combination where the patient voice can be heard and amplified. We have separate boards, we have separate staffs. There are crossovers, so Stuart and I happen to be crossovers on both, but we have separate boards, separate staff. We are hand in glove, but we are two hands. And again, thanks for being with us. The DPAC group, if you are new, we have grassroots advocates in every state. If you're new to us on this call, we would really welcome you to join us and please sign up on diabetespac.org. We'll hit that website again at the end, but please join us. We are all across the country, and there's power in numbers, and we have power. So housekeeping notes before we get started here. This meeting is being recorded and can be accessed via Facebook Live. So we urge you to, if you haven't, can't watch the whole thing, or if you want to watch it again, you might want to get a like, but if you want to watch it again, please do so and share it with your friends. So we would like this information to be shared because this is a really important topic. If you've got questions for our presenters, please feel free to enter them in the Q&A feature on the bottom panel. If you have any technical difficulties, put those issues there as well. We'll do our best to help you out. There's a survey at the end, which we certainly would always appreciate your feedback on how this event goes, and anything that we do, we welcome your feedback. And sit back, relax, and enjoy the presentation. So let's get started. What in the world is a rebate?
Perverse incentive.
You're right. It's a perverse incentive. It started out, I mean, my first memory of a rebate, it's a financial incentive to buy a product. But my first memory of it is a car. You buy a car and you go in, you spend 25 grand on a car, 20, whatever it was, and you got $2,000 back. So it was a kickback at the time. I would left the dealer and I had money in my pocket to go, go on a trip. It was great, but it was coming to me. It was different. It was a different.
I was going to say, George, what's the difference?
Yeah, the difference.
What's the difference, George? The difference is that money came to you. In this scenario, the money goes to the insurance companies. So this is a whole different deal.
Yeah, it's exactly right. And in the case of prescription drugs, they're based on a volume-based incentives to gain access to the market. So the volume of drugs sold goes up, the amount of rebate goes up. So which means the net price of the drug is going down. We're going to pause for a second and show a quick video that I think will give everybody a nice understanding that this DPAC put together this video, and it's kind of an explainer video on how rebates work.
Millions of Americans rely on medications to manage their health, but existing rebate rules mean higher costs for people with chronic conditions like diabetes. Before patients are able to purchase their medicines, insurers and pharmacy benefit managers negotiate prices with the pharmaceutical company. Pharmaceutical companies provide rebates to reduce the total cost for many medicines. However, those savings are often not passed along to consumers. With rebate reform, middlemen would be required to pass through those savings, making drugs more affordable for patients. Supporting rebate reform puts patients first and promotes access to medicines they need. Join the fight.
Get us right back to here. So let's talk about where these rebates are found. And the answer is everywhere. This is every drug out there, and it's across every chronic disease, every chronic condition, diabetes included. You look at these stats here, what these percentages mean is the amount of the list price that is inflated. So in fast-acting insulin, 73% inflation in the price versus what the net price is and should be to patients. But it goes across all of these other diseases, asthma, hepatitis, all of these drugs, and all of these areas and the drugs within them are being hit by this. So people with diabetes are not alone in our fight and our push against rebates. We have a lot of allies in this fight. And it's really important that we understand that.
But George, what's an important thing to point out is these are not generics. Generics are on this, or most generics don't pay rebates. And I remember when it used to be your health insurance pushed you generic, but now formulators aren't doing that. Isn't that true?
That's absolutely true. And pause for 2 more minutes and we'll get into just a hair curling, to the extent that I have any hair left, slide that will make exactly that point. But as Stuart is pointing out, all of these, you're on a brand name drug. Those brand name drugs are inflated by these rebates, and that's not the case in the generic drugs. The biosimilar drugs don't have the level of rebate, or any rebate in many cases, involved in them. So when did rebates start? Why are we having this conversation in 2021? We've been talking about it for several years now, but we haven't been talking about it for our whole lifetime. The Medicare Prescription Drug Improvement and Modernization Act of 2003 established really Medicare Part D. That's the law in 2003 that provided a drug benefit within the Medicare program. As they negotiated that, it also created a legal pathway for price negotiations by exempting rebates from the federal anti-kickback statute. And it required the middlemen to be hired, these pharmacy benefit managers. It required the federal government to use pharmacy benefit managers to negotiate and establish the pricing for the Part D formularies. That's the part where it said, where you often hear that the federal government cannot negotiate on behalf of for drug prices directly with manufacturers on the Medicare program. They actually did that to themselves in the 2003 law. So who are the pharmacy benefit managers? Those of you who are old enough to know the SPY versus SPY communicating, who are these folks? Well, let's meet them. They are all across the board here. The thing to note is that they're buying each other. So you have an insurance company, United Healthcare, Aetna, Cigna, Humana, Anthem. You've got the PBMs that are setting up the drug pricing process for them. But the thing you may not obviously note here is that they own each other. I mean, you see Optum, CVS, they own each other. So they are sending you exclusively to their mail order pharmacy, their specialty pharmacies. It's no cheaper there, but they make an extra $1 or $2 when they do that. and they're owning the whole thing. Everybody is in bed with each other.
George, important part of this, however, and please don't focus on this slide because it just hurts your eyes. But the important part of this is who owns them are the insurance companies. Now, I have been licensed to sell insurance for over 40 years. So, but I will tell you that who owns them are insurance companies. So it's not PBMs owning insurance companies, it's the other way around. So, and we all know insurance companies treat everybody fairly in the healthcare field and always want to pay for everything that you need. I'd go to the next slide before I get upset.
and clearly we all know that the insurance companies are just here for you. That's exactly how it works. So what does a pharmacy benefit manager actually do? Well, they actually do have a purpose. They negotiate drug pricing on behalf of the plan. So they're setting everything. They're establishing the formulary of what prescription drugs will be covered under a health plan. And then they process the drug claims. So they have a transactional, impact. Every single time you buy drugs, at the pharmacy, the PBM is in fact processing that claim so that ultimately you get paid or the drug company gets paid. They're the ones doing that work. And their job is to lower the cost of prescription drugs for the plan. But understand their customer is the plan. Their customer is not the patient. It's not us. Right. So they don't care if it goes to the patient.
And the important thing to remember, George, is these were very good things that PBM started out to do. It's when they started changing, particularly in number 2, if you add the word exclusionary formulary in there rather than regular formulary where you exclude drugs. I mean, they send me a note and say, hey, you got to use a different meter to test your blood sugar. We're changing you off of this drug and putting you on this drug. I bet everybody on the call has had that happen. That's a result of an exclusionary formulary and a result of profit and not good healthcare practices.
Yeah, and that's a really good point in a couple of things. The exclusionary formulary, as they're playing their negotiating games, it is an all or nothing game. That's one thing for us to realize. That's why we see non-medical switching. The other comment I want to touch on there is it's not just drugs. It's devices. It's our CGM sensors. It's our test strips. It's anything that's running through that part of the benefit plan. The PBM is got a finger in their pie. And one of the most disgusting examples here, and this is where, Stuart, you were going a moment ago. They have a perverse incentive. PBMs and the plans, they get more money when they cover the higher priced brand drug rather than a less expensive generic or biosimilar. It's a perverse incentive. So here's some stark examples. This is Medicare Part D, 2016 to 18. First generics. So when a generic medicine launches, it typically saves 30% off of the brand name drug, yet only 1/4 of them are covered in the first year. It's the PBMs are not welcoming these new generic drugs with open arms. In 2020, last year, less than half of all of generic products were actually placed on generic tiers. When a generic tier in a drug pricing scheme is going to be the lower cost tier, so that the patient, you would actually pay less because you're now getting that generic or that biosimilar, that drug that is 1/3 or typically more less. And over the last decade, generic coverage on generic tiers dropped from 93% to 45%. Now, why would they want to not incent you to take the low cost drug? It is.
I'm sorry, were you asking me a question, Georgia? If you were, the answer's pretty simple. Money, 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 money. It's pretty simple.
And you are so right. Now, so let's follow the money.
Oh, I hate this slide, George. Okay, so if you take your hand and put it over the left side of your screen and cover that up right now, what you'll see is what it ought to be. In other words, it's what it is in other companies. Anybody ever heard that drugs are cheaper in Canada or Mexico or in Europe? This is why. This is a diagram. It's not our diagram. It was published in a American Diabetes Association journal. This shows the money and the drug supply chain. Now, let me real quickly, because I know we only got a half hour and I could spend an hour and a half on this. We're the consumer up at the top. The blue line represents a vial of insulin or a drug, okay? You go to the pharmacy and you pay your deductible or your copay. The pharmacy either orders from a drug wholesaler or directly from the company, depending upon how big the pharmacy is, the drug or the vial of insulin that you want. The pharmacy then dispenses that to you. And then they turn around and pay either the drug wholesaler or the drug company. Sound simple? It is. Sound like the American economy when you buy any other product? Exactly. Now, Georgie, since you're a CPA and I can barely do my own taxes, would you please explain the whole left side of this thing?
Well, the short answer is it's impossible to truly explain, but we'll do our very best. So you follow the bouncing dollar signs, really. So the drug company is sending the rebate back to the pharmacy benefit manager. And it's, again, 70% of a vial of insulin. We'll do that in a second with real life examples. So this money goes to the pharmacy benefit manager. The pharmacy benefit manager is keeping a chunk of it and then sending the balance, most of it, honestly, up to the insurance company or the health plan, which is the self-insured employer. It's the Aetnas, the Cignas, and the Humanas on that chart we had before. And it's also the federal government in the Medicare situation. So these rebates are going back up to the health plan, but they're not going over to the consumer. There's no green line here to get to the consumer. So the consumers, we are paying an insurance premium to get access to the plan, but we're not getting the benefit of the negotiated price that the plan is actually paying. So the consumer all too often is paying full list price or paying a co-share based on full list price.
So, George, what happens if I don't have insurance? Can I just go in and buy it at the net price?
No, not exactly. No, if you don't have insurance, because the contract that the pharmacy benefit manager has with the insurance company, excuse me, with the drug company, is that they can't sell it for any less. So they're not allowed to sell it for anything less than the deal they've got over here. So the uninsured are completely exposed to list price.
So uninsured are still paying rebates too, in other words.
Exactly. The uninsured are paying a completely inflated price, and those funds are going in many cases nowhere. Well, in many cases, actually, the drug companies want to keep that because they're not going to pay the pharmacy benefit manager because there's no pharmacy benefit to go through. But a lot of those folks are also in a Medicaid and some of those other scenarios, which are off topic for today's piece.
Okay, George. So you take insulin every day to live. You have to have it or you die. I mean, it's just that simple when you have type 1 diabetes. Mm-hmm. So what's your own experience with buying insulin?
This is, in fact, my purchase of insulin in February of 2021. I go to CVS right near my home, and the list price, the retail price for the vials of insulin, I bought 6 vials that day, were $334 per vial. The net price, which oddly enough was disclosed to me on my receipt, was $85. Now, the good news is I'm the plan administrator of my company's plan, and my company passes these rebates through. So I paid $85, but I saw that it was $334 and my cost was only $85. Now, $85 is still a lot of money during the deductible period, but I was able to do that. But here we've got, competition is happening. There's multiple brands out there. There's biosimilars coming on the market. When competition rises, prices usually drop. And the reality is, and we'll show this in just a second, prices are in fact dropping. The net prices are dropping. The list prices, however, are going up. And
so, George, George, we had a question, and so let me as we go through this. The question was by Mike was what percentage does the PBM keep, and what percentage does the insurance company keep? And I think the answer to that is PBMs say they only keep 2 or 3%, and the insurance companies say they keep the rest of it because they are trying to make premiums lower, which I don't know anybody whose health insurance premiums have gotten lower unless they drastically increase their copays and their deductibles. So, Mike, to answer your question is we don't know because there's no transparency in the system. Insulin companies are not allowed to tell what the rebates are. All of our information we've gotten from reports that have been issued to Congress and other areas, but they're not allowed to tell because that comes under the federal government of saying, oh no, that's price fixing. You can't do that, or we're going to get you, we're going to sue you. So there's no transparency in the system whatsoever. George, what did I say that was wrong?
Not a thing, not a single word. Yeah, and you know we don't know exactly what the cut the PBM is keeping, but we know that it's a cut. Okay, it's not zero. And it's probably now down. I think there's been a lot of price pressure that they are passing more and more of it up to the insurance company, but it's not zero. And I think back in the early stages, they were keeping more than perhaps they are today, but we just don't know. But you can see here what's going on with list price since 2012, up 141%, and net price is actually down 53%.
And George, we had another question,
Sure.
and that question comes from Scott, and he says, well, now how do people bypass PBMs and insurance companies and use GoodRx or other type or a copay assistance card? And the issue for that is, and George, I'll answer it. If I misspeak myself, you correct me. You're going outside of your plan, which means you get no credit towards your deductible, no credit towards your copay, no credit towards your coinsurance percentage, but you're paying for it. And sometimes you can't get it cheap, but not always. Right, George?
Yeah, and I'll add one more twist to that. It's exactly right. You're outside of your plans. You're not getting credit for your deductible. You're going out of pocket 100% on that when you're going to a GoodRx. In some cases, they've got better pricing. In fact, in most cases. The other thing to be aware of is GoodRx is a PBM. They have negotiated, they're a PBM. They've negotiated this. You're paying a price through GoodRx that may be lower than this top list price, excuse me, but you're not paying $85. You're paying something along in here. And GoodRx is buying it down here. GoodRx is just keeping all of it. So it's a brilliant business model. So most of the uninsured can buy through GoodRx and get it honestly cheaper than an insured person can during their deductible in many, if not most cases. But GoodRx is in fact keeping that middle, that differential between what you're paying and what they're actually buying it for. They are a PBM.
So George, what's the government doing?
Well, they're writing reports. So that's a good first step, right? So this is actually a really important report, the Grassley-Wyden report that came out on examining factors driving the rising costs of a century-old drug called insulin. It came out in January of this year. So this is extraordinarily timely information. I urge anybody on the call that wants to really get deep on this, you can get through this. It's about 90 some pages. In this report, they literally have an email from a drug manufacturer executive on record saying they are afraid to lower the list price because they will lose market share. They're afraid to lower the price because they're going to lose market share.
Now, George, in your intro of me, you talked about how long I've been around, and by the gray hair, you can tell I've been around diabetes a long time. We've had many, many reports get written on diabetes, federal, Congress, everybody. What's to keep this report from getting put in one of those cases like an Indiana Jones and get stored in a government warehouse with the Ark of the Covenant, and we'll never see the light of day again?
I love that analogy. The only thing that's going to keep that is us, is advocates. It's making sure that we continue to shine a spotlight on this issue and all of the things that came out of this. The good news out of this, I think Senators Grassley and Senator Wyden both really do understand this issue now, and we're hopeful that they will be part of putting some potential solutions out there. But we have to keep the pressure up. The noise level has to stay. So what has the federal government done to fix this? And, you know, there was an executive order put out by the Trump administration last year in the fall. The Biden administration has put it on hold and postponed it to 2023. The executive order required rebates and discounts to be passed on to patients in the Medicare Part D program. So on the surface, that's a great thing. And it really would be, and hopefully someday will be, a great thing. When the rule was written, it also said there could be zero increase in premiums and zero cost to the federal government. So they put a poison pill in the executive order. Now the executive order has been challenged in the court system by the PBM's industry association, if you will, and it's stuck in a legal morass. So this thing is stuck here, and it's just not in a good place. And then you look at federal legislation, and we really haven't gotten anywhere. There have been a couple of bills put out, but really at this point, it's all talk, no action, and which gives us a plug for the Less Talk, More Action campaign that the Diabetes Leadership Council has launched. And hopefully you'll find us on in Facebook, on social media, Twitter, etc., on a plan really just highlighting, and we've run this, and it's even on ads on CNN. So if you were in the Washington, D.C. area and you're watching CNN, you will see during June and July, with the exception of July 4th week, a 30-second ad trying to push Congress to make some motion on rebate reform.
And George, Nessa has asked a question. Nessa, hold on. We're going to answer your question in the slides near the end of this presentation. So all talk, no action. Every congressperson that runs says we're going to do something about insulin. We're going to do something about nothing's happening. So now it's going where, George? Because nothing's going on at the federal level, what's happening?
It goes to the states. So the states have introduced rebate legislation, rebate pass-through legislation. 11 states have introduced bills. West Virginia is the first state to require rebate pass-through, and they required 100% rebate pass-through. We testified on that issue, and they were bold enough to go forward with it, which is fantastic. New York is actively considering legislation. 11 other states tried. And as we've seen this in insulin copay caps, copay accumulator programs, diabetes action plans, you take it and you try to create a wave of momentum across the states to hopefully get some relief for patients with diabetes and maybe get Congress's attention.
But what's the problem, George, with state action?
Yeah, well, the problem with state action is it only impacts state plans. So you're only getting 10% roughly of the people in that state that are on a state level plan, perhaps in the state government or municipality. So it really has limited impact. So who gets the money? And don't you love this? John Travolta is, who gets this money? And it's the PBMs, it's the employers in self-insured scenarios, it's the insurance companies, it's the federal government. Now, who can fix it? Congress. The same folks who got us here in 2003 are the folks that need to fix it in 2021. And hopefully not 2023. We need to do this now. But it is not easy to fix because all of these folks, they're thirsty. All of these folks are taking really big drinks from the river of rebate money, and they're all drunk on it. This is money that is non-accounted. It's unaccounted for. So I myself as an employer, and I'm the plan administrator of a self-insured health plan, have been for 20 plus years. When I first started getting rebates, my plan administrator, third-party administrator would bring me a check, and I'd get a $40,000 check from him in a meeting. And I wanted to hug him. I'm like, oh my gosh, I had no idea this was coming. And here's 40 grand, which to me was a lot of money. To some of you guys, that's chump change, but that meant something to me. I'm like, thank you very much. Now, I had no earthly idea whether that was the right amount. Should it have been 45,000 or should it have been 37? And I really need to thank the guy. I didn't know what it was for, but the fundamental thing here is I could do whatever I wanted with that check. There was no accountability to me. It wasn't in a budget line. I could do whatever I wanted. And these guys are not willing to give that up. And that's one of the bigger things that we're buffeting through. That's one of the bigger pain points of why insurance companies and sometimes employers and government doesn't want to give this up, because it's a slush fund.
Well, and it's also, they take some of that slush fund and spend it on lobbyists and attorneys to fight any changes to this whole system.
Yeah, you're exactly right. You're exactly
okay.
right. So what are we asking for? Well, clearly, let's get rid of this kickback safe harbor protection on rebates. Let's stop that foolishness. Let's pass through these rebate savings to patients at point of sale. This is not that you're going to get a check back after you've bought your insulin. The net price is what you should be paying at the cash register, or what your co-share should be based on at the cash register. Let's just make that the law. So you're paying a premium to get access to a plan. You should get the value that plan is negotiated on your behalf. And let's remove the PBM's incentive for using the higher priced drugs. They should not be getting a percentage of the transaction. Their incentive should be saving money and going to the low cost for everybody. And that, if we did that, all patients should pay net cost, not list price. This is including these uninsured folks. And this has to be done at the federal level, because otherwise you're never going to impact these ERISA plans, the employer plans, et cetera, that's out there.
So there's no bill, George. So right now, if I called my member of Congress, who knows me very well, unfortunately for him, I can't share with him a bill. But what my good friend Larry Smith and I have done is share with him that there's a problem with rebates that need to be fixed. So when we can get a bill, if I've talked to that member of Congress, they're going to go, aha, I remember Stuart talking to me and telling me that there's a problem. This is probably something I need to look into. We've got to raise awareness on the issue, right, George?
Exactly right. Exactly right. And let them know you care and that this is an issue that's important to you. And DPAC will be turning on its engine as soon as we have something actionable to get involved in. And we may just do it just to say, please, 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 please pay attention to this. It's so important right now. This is a pivotal moment in hopefully our time and our history this summer, as these topics, and you're talking about reconciliation bills, you're talking about infrastructure bills. These are the kinds of bills where rebate reform can get tacked within it. And we are really hoping to get some action and get some interest on this. You may not see a bill that standalone says rebate, but you may see a bill that includes help on this issue.
So George, can I share the DLC DPAC stuff on social media? Where do I get it?
Well, I do hope you will. So please check the DPAC page. Definitely has these links on it. And we'll share them again on that DPAC page so that they're fresh. But they're right there on there, the DLC page as well. DPAC also has shared it on Twitter. So follow DPAC on Twitter. We welcome that. Also, there's a video, DLC, Diabetes Leadership Council. We have a program where we educate employers. Now, this is a 50-minute program, so don't do this unless you've got some time, but share it with your employer. And we actually talk about health plan design features that the employer should use and care about to lower their cost, lower their plan risk for their participants that have diabetes. And there's some real tangible things on here. And we just did a program on June 2nd through hr.com. That video is up there at no cost to anybody who wants to view it. And we welcome that getting shared.
So George, we had another comment question from the viewership, and Carol reached out and said, the word rebate is a good, what you're telling me is it's a bad thing. No, it's not a bad thing, Carol. It's a good thing. However, it needs to be passed on to the people writing the check. It doesn't need to go to the nameless, faceless insurance company or PBM. It needs to go back to the patients. The center of this whole discussion is about patients. Who should make decisions on your healthcare team, and you? Who should get the money when you write a check for a drug? Whoever's supplying it, and if there's extra, it should have come back to you in a discount or a rebate at the very first. This is all about, yes, rebates sound great. Why do you think they came up with the word rebate instead of calling it something else, which I can't say because I got yelled at last time I did? So let me say this, you're right. And that's what this is about, because we need everybody to join us and become a DPAC champion. And if you are a DPAC champion, we need you to ask your friends and family to join. We've heard the old saying, if it takes a village, it takes an army. And we've got to fight. And we've got to fight for people that can't stand up for themselves and fight for ourselves. So, George, how do I become a champion?
I'm glad you asked that. So go to the DPAC website, diabetespac.org, and sign up. And then take the action. We do the heavy lifting for you. We go through and distill the issues and make it actionable for you. So when you get an alert from us, click on that alert, and it will create a letter already targeted at your specific senator or your specific representative. We do this at the state and the federal level. So we get involved in all kinds of issues, all those state issues, as well as Congress. And we're talking about a federal issue today, primarily a federal issue, but get involved. So sign up and take action, and then join us for this event. I would really appreciate your attention today and some great questions and great participation. We're going to be holding an in-person Hill Day someday, probably 2022, where we will be on Capitol Hill. We've been on Capitol Hill before the pandemic. We hold brown bags, policy briefings. We're on social media. Follow us. We're trying to keep everybody tuned in to what's going on in the advocacy world. The only thing DLC and DPAC do is advocacy on behalf of patients with diabetes. So please follow us and stay in touch. And that, we're a few minutes over. It's a deep topic, so we really appreciate your attention and hanging in there a little bit longer for us. Diabetespac.org has great information. Diabetesleadership.org has the Less Talk, More Action campaign and some specific things. We will be sharing those links after this presentation. And any other questions, please, don't hesitate to reach out, contact us, info@diabetespac.org, info@diabetesleadership.org. We are delighted to answer your questions and really appreciate your being engaged and your being an advocate on behalf of people with diabetes.
Do me a favor, get mad, take action. I'm tired of talk. It's time to go to work.
Yeah. Amen.
Thank you.
Thank you all so very, very much.